the merits. It's the best thing for supporters of Obamacare.
Art, can you pick up on that thread and talk more about the implications of this moving forward?
Yeah, the big implication of the teachers walking through the fact that this was a clean victory because they didn't even get to the merits. So if you're defending Obamacare, that's a good thing. The Democrats in Congress have their own agenda, and we've heard them celebrating this or saying it's the path to do more or better. That's a policy debate. People can decide whether to do more or not with it. What I can tell you is this fortifies the fact that every time the Supreme Court, even with different membership, has looked at this issue, they have found Obamacare is lawful, legal, constitutional. You can tweak it, you can change it. States can debate it, but never.
Hi, Shannon.
Hi, how are you?
Thank you for your help on this.
Yes, no problem. There's a few other people that did join, but they dropped back off.
Okay, we probably, other than the people that are doing the presentations, we probably should wait till about 11:30 to let people in. Although Gregory, you can stay on if you want.
Sounds good. So Dave, it'll be Eileen, Tanika, and Lisa Weaver. And
Right, they'll be doing the sharing, right?
okay.
Why did that happen?
And there's one other person that needs to be admitted early, correct?
Jim Bennett.
And Laura Well?
Laura Welliver, yeah, she should, both of them probably should both be admitted.
Okay.
And then Shannon, I'm going to come in later this afternoon. And I know Derek said he would help as well with some of the more refined details of this. So,
well, I'm going to get the file pretty much afterwards on the chat. So I'll just save that and send that to you. Okay. But it'll take about maybe an hour, a little bit more to get the recording. So once that does come through, I can send that to you as well.
Okay, great. Mm-hmm. Everything else okay today?
Yep, busy office today.
Yeah. I was going to try to go on Aaron's tour, but it was just going to be hard to do that and do this.
Mm-hmm. Yeah, you would have probably ran over.
Yeah. And then you'd be stuck running everything.
They're not back yet, so.
They're still not back?
Mm-mm.
Yeah.
Yeah.
I figured they're going to take till at least noon. Just the walking part's going to be tough enough.
Yeah, I think so too. I think so too. So you'll be able to join us at 3:30 then?
Yes.
Okay, good.
Deb and I have been emailing back and forth about that for a week.
It's exciting.
Yeah, I think it's a neat idea. It's, bonding is really important, and getting people to feel like you're part of a team is really significant.
Yeah.
And I'm grateful that people think of me as being part of that team.
You are. You've been. At least ever since I've been here.
That was about the same time, I think.
Yeah. Good thing that Randy did.
Yeah, there were some good things.
Yeah.
Despite what people want to say.
Right.
Yeah.
So how many do we have signed up today?
Derek said, I think we had just about 100.
Good.
And we don't get them all the time. And I know there's a couple of people wrote me and said they might be late. So can they get a copy of the recording? And I said, yes. So.
Okay, good.
So that's good. It's been pretty constant around 100 to 120. It's actually sort of, as you remember, 1,000 years ago when we did this in person, we'd have decent crowds, but these crowds have been pretty good.
Do you feel like we'll continue doing them virtually?
I think at least through September, and we'll have to see after that. And my thought is maybe what we do is alternate them, one live, one online, depending on the topic and depending on the time of year. But we've had good response with people doing it online. The only real challenge has been people don't feel like they get to be as engaged as what they were in live when they get to ask questions directly.
Yeah. Agreed.
Yeah, but trade-offs, that's what life's about in part.
Mm-hmm. Greg, I like your fancy mirror there. That's nice.
Yeah.
Let's get you off mute.
So hopefully we'll have a couple of people joining us in a couple of minutes.
Yeah, there's a couple that aren't on the list for early admission, but.
Yeah, it's amazing to me how many people show up early, which is sort of neat.
Yeah, it's good.
Yeah.
Greg, you're on mute. There we go.
There you go.
Yeah, I said I had it on my calendar for 11 o'clock this morning.
Oh.
I guess I made a mistake. Yeah.
That's okay. You're more than welcome to join us. You're gonna see the behind the scenes stuff for a few minutes. So
all right, good. Yeah.
Better early than late.
Yeah.
Yeah.
I got to get ready to go to a big Olivets event tonight at the baseball stadium. Yeah.
Yeah. There are a bunch of big events tonight. I know John Weidenhammer, who I work with, is doing one for Opportunity House.
Oh,
Something about wine women in shoes or something like that at the airport.
Yeah, well, good.
Been flexible. Olivet's doing that outdoors at the baseball stadium, and they're doing this up at the airport.
Wow.
We're doing a lot more outdoor engagement than what we had before.
Well, down here in Delaware, a lot of things are going back to normal, especially restaurants. Restaurants have totally opened up.
Yeah, it's really happening here as well.
Yeah. But, their biggest problem is they can't get the help back.
People are struggling to find workers for everything, not just the restaurants, but lots of jobs. People just, I guess, somewhat reluctant to come back, whatever.
Well, yeah, I think there's two categories. I know at Penn State Berks, a lot of people made the decision to retire early rather than come back. So there's a big crowd of that. And there's others that are shopping around for jobs rather than coming back. They're out looking around.
Yeah, looking to see what they want to do and see this as an opportunity. And a number of people have decided if I don't have to work in an office but can do it remotely, maybe I'll pick up and get a job in Kansas and live in here. I was talking with a guy who has a job in Redding yesterday, but is living in Southern California.
Yeah, well, all I can say is that'll keep the airline business booming.
Moving, yes. And hopefully, one of the things we're working on is trying to get passenger trains to come back to Redding. Hopefully that will help some too.
Yeah, well, I hope you make it. But, I'm right on the Amtrak line from New York to Washington.
Right.
And, I use it a lot to go to Washington. But it's slow. It's not that fast at all.
Yeah, this would, it's faster than going on the Schuylkill Expressway.
Oh yeah. Well, that's a parking lot.
It's not a 120-mile-an-hour train that we're talking about. Yeah. Eileen, hi, how are you? Thank you for doing this.
Hey, yeah, no problem. Thanks for inviting me.
And we've got Laura Welliver, who's on from Penn State Berks, the health system.
Good morning.
Morning.
Eileen, tell me how to pronounce your name correctly again. You've done it before, I know, but.
No worries. Yeah, Devringi.
Devringi, okay. And we've got 2 other people coming on from Penn State Health System, and then 1 from Tower Health. So we're going to start with you. We can right now try to see if we can get your presentation up if you want to do that.
Yeah, I think that makes sense.
Shannon, can you give her, thank you. You're so good.
Trying to get it full screen. There we go. Did it go full screen?
Yes, looks good. Good. Great.
So Dave, I know Lisa sent you a PDF version of ours last night.
Right.
She's probably made some additional tweaks, and she should be on in a moment. And
Okay.
she will probably try to run the slide. There she comes.
There she is, and there's Tanika.
Run the slides live, and she can test them out in a moment.
Yep. And we have Tanika Mason, who's on from Tower Health. Tanika, how are you?
I'm good. Good morning. How are you?
Good. Why we've got you talking right now, why don't you, we'll give you the ability to share your screen, and you can test to make sure we can see your slides.
Sure, sure. Okay, let me know. You should be seeing them.
Yep.
Okay, you should be seeing just the full slide.
We see the full slide in the next slide. However,
Oh, you see the full, so you see like my, the black screen.
Mm-hmm.
Yeah.
Yeah. I have to change it out of this kind of.
And Dave, Jim is in the waiting room as well.
Okay, let him in.
I don't know that you let him in. Oh, I see.
We will. Shannon will let him in.
Okay. Okay.
Okay. How about that? It should just be the slide now.
That's it. Very
Okay.
good.
I just got to make sure it's not in presenter mode. Okay.
Okay. So Lisa, we'll let you up in a minute. Okay.
I don't see him in the waiting room.
Yeah, I don't either. I'm not sure if I hope he's not in another waiting room. Oh dear.
So Lisa will give you the screen and let you try yours.
Oh, there we go. Okay. Tanika, it sounds like.
Hi there.
Hi, Jim.
Oh, okay. That's what the confusion is.
Good.
All right. Are you seeing my slideshow?
Yeah, we are.
Perfect. It's advancing. Okay, great.
Good. I think we're all set. So what we'll do is I'll start off with an introduction. If John Weidenhammer is joining us, I'll have him say something on behalf of the Berks Alliance. Then we'll go through some ground rules. We're going to ask people to stay muted while they're watching, hopefully to stay visible so we can see that they're live people that we're talking to use the chat function to submit comments and questions, and we'll compile those. We have time at the end of this. We will ask them, but regardless, I'll compile the whole list of comments and questions that we get from the audience for everybody and share them with you guys so that you have them and we can get that response back out. As you may know, you can see in the upper left-hand corner, we're recording this, so everything stupid I say is being recorded. We'll start with Eileen and let her go for, what do you think, about a half hour?
Yeah, thereabouts.
Okay, and then we'll turn it over and any preference about which one of you goes first? We have a fist fight between Penn State and Tower Health.
No preference.
Well, Tanika, why don't we let you go first?
Okay.
You, and then we have the 3 people from Penn State, and that will give us a little bit more time with them. When we get done with it, if we have time, we'll open it up for questions, and I'll ask the questions that the audience has submitted. We'll try to have a hard stop at 1 o'clock. Sometimes we go a little bit longer, but not too much longer than that to respect people's times.
Sounds great.
We have about 100 people registered for this, which is pretty good. We won't get them all showing up, and because I know a couple have told me that they might be late or they might have something else that they have to do, but we'll be recording it. We'll send you guys a copy of the recording. You should feel free to use it as you need to, as you want to. We will send it out to everybody who registered for the event, and we'll post it on the Berks Alliance website, so it will be out there. We'll also send it to BCTV, who will post it on their YouTube, so it'll be fairly broadly broadcast.
Great.
Do you guys have, and then, as I said, I'll close it out at 1 o'clock and talk about the next couple of community forums that we're going to be having.
Okay.
So thank you guys for doing this. I think it's a very fascinating topic, and you guys, I know, both institutions are stepping up pretty big time in the community, so, which is good.
It's a very timely topic, so thank you for having us.
Sure, and as Eileen will tell us, meds can be very significant anchors in lots of ways in communities. So, do you guys have any questions? Anybody have any questions? Okay, Jim, should I call on you first for Penn State, or do you want me to?
Yes, please. So what we'll do is I'll start by just kind of running through the front end of our slide deck. I'll hand it off to Laura, and Laura will hand it off to Lisa. Okay. And then I will just close with, some regards and thank yous, etc. I guess the question for so once I do that, will that be your cue to kind of, or somebody's cue to kind of say,
yes,
that completes our presentation today, kind of thing? Any questions? Okay.
Yeah, I'll step back in on that. That's good. Thanks for telling me that.
Yeah,
sure. It's always good to have cues.
So that just brings up a question then for myself. So should I pass it off to you, Dave?
Yeah, you can pass it back to me.
And then Dave will pass it off to Jim?
Right.
Okay, sounds good. Okay.
Yeah, and what I think I'll do is I'll very quickly say we're going to have the presentation by the Federal Reserve Bank, followed by response presentations by Tower Health and by Penn State Health St. Joe's. And then I'll introduce you, Tanika, and then I'll introduce you, Jim, when you come on. If you want to introduce Lauren and Lisa, that would be fine, or I can do that.
I was planning on just having a few things to say in my introduction, so
okay.
I'll take care of that.
Okay, good.
Oh, which, by the way, neither of them need any introduction in this group of people because they are incredibly talented in this.
Yeah, I've been leaning on Lisa for a long time.
There you go.
A great group to be working with.
Okay. Well, we've got about 5 minutes. Shannon, when we get to about 11:27, 28, why don't you just start letting people in? It takes a little bit of time to get them in, so.
Eileen, it's Jim Bennett. How do you pronounce your last name?
It's Divringi.
Divringi. All right, very cool.
And I can spell Tanika's name right now.
I didn't even notice that. I was like, oh.
Disha caught me. Disha's people.
I mean, at least I've gotten worse. I've gotten like an M or like completely off. I'm like, that doesn't even sound like Tanika.
Oh my.
I have a simple name and everybody always either puts an extra E in it or leaves off the S on the last name.
Yeah.
It's like, come on, it's not that hard.
It's not that hard.
Absolutely.
Oh. Well, we may lose people because it's such a nice day outside. Maybe they're outside doing stuff and pretending.
I was just thinking the same thing. We've been blessed with good weather the past few days.
Eileen, you're still virtual, right?
We are, yeah, for a while longer, I think.
But it makes this commute easier for us to do it this way for you.
It does. Yeah. I feel like I've actually accepted probably like 70% more webinar invitations because of that in recent months.
Oh my God, that is terrible.
The famous Mr. James Bennett. Dave, you get to see him now. That's awesome.
Hi, Missy.
Hey, Jim. And Tanika, too. We got the rock stars right on my screen. They're side by side, so that's awesome.
Thank you.
Okay, we're getting there. Got a couple more minutes.
Hi, Dave. Good morning.
Hi, John. How are you?
Hey, I'm doing super. Hi, everybody. Thanks for being with us.
Hi, John.
Good morning.
Hello, Mr. Weinhammer.
Oh, Tammy, nice to see you, hear you on the call. And Jim, thanks for joining us. Hi, Tammy.
Hi, it's great to be here.
Yeah, yeah. So we all teed up, Dave?
I think so. We're still waiting for people to get in, but we had 100 people register for it. We have tried the slides and they seem to work. And I think we're pretty good to go here in a minute, and we'll get started.
Awesome.
I'll do a quick introduction and then turn it over to you, and then come back with the ground rules and introduce Eileen.
Okay, and I'll be brief. Eileen, thanks for being the lead batter here on this presentation.
Thanks for inviting me.
Well, you're quite welcome. You and your team have been a great help to these conversations that we have, and your input is really invaluable and valued very much by us.
Thanks. It's always great to have local partners like the Berks Alliance to help sort of add meaning to what we do. Because, we can put our research out there, but, it takes these partnerships to really get it in front of people. So we definitely appreciate it.
And I'm sure that's frustrating from time to time that, you do this great work and really put your heart and soul into a report, and then, you don't really get any feedback. So you don't know, does everybody love it? Does everybody hate it? Did it fall into a black hole? What happened? So, we're very keen on giving you and the team there a platform for, explaining to the community, some of the great work that you do, but helping to create context, because, I think, one of the great values of having you on these calls is that you not only, give us the data and the numbers, but you add, context to it so that people can really relate to it and consume it in a way that, is beneficial because you're interpreting it for them.
Okay, we're at 36 people signed in and more coming, and we're at 11:30. So if everybody's okay, why don't we'll launch with the things that people don't need to hear, mostly from me. So I'm Dave Myers. I'm the director of the Berks Alliance. We want to welcome you all to this community forum. We do community forums on the third Thursday of the month, not every month, but pretty much every month. We will not be doing one in July. I'll talk later about our schedule going forward. But they're, we think, a great way to engage the community in conversations about important topics to the community, to try to stimulate interest and catalyze action on some things. I'm going to come back with some ground rules in a minute, but I want to turn it over to John Weidenhammer, who's the chair of the Berks Alliance Investor Board. John?
So thanks, Dave. Good morning, everybody. I wanted to start by thanking Dave and all of our presenters for arranging this really important topic and putting together what I think is going to be a great presentation. For those of you who may be new to these presentations, the Berks Alliance is a collaboration of anchor institutions in our community. And we're really focused on community development, and we define that as working to improve the health, wealth, and education attainment of our community, to also make sure that we have great communications through these kinds of forums. We want to make sure that we have a safe, clean, and green core of our community. In addition to that, we work to make sure that there's an adequate supply of living wage jobs in our community, as well as an adequate supply of people to occupy those positions. So thank you again for being here. We really appreciate the support that we get from the community, and I'll turn it back to Dave to get things rolling. So Dave, back to you.
Great, thank you, John. I'll cover the ground rules first and then do a quick introduction to our topic. We'd ask you to stay muted during the presentation so that we don't have a lot of background noise. If you are not familiar with Zoom, at the bottom of the screen, there's a thing that says chat. We will ask you to submit your questions and comments via the chat box. We'll compile those and we'll be asking those questions at the end of the program. Any questions that we do not get answered, we will assemble them and send them to our presenters and ask them to respond, and then we will share that with everybody who registered for this event. We're also recording the event. We will make it available to everybody who registered. It'll also be available on the Berks Alliance website, and we will probably be posting it with BCTV on their YouTube website as well. So you can see this over and over and over again, if you'd like. This topic is really, really important, and it's sort of fundamental to why the Berks Alliance exists. Back when we were forming this organization, we looked at a lot of other communities and what was happening there with what were perceived to be the anchor institutions, largely the universities and the health systems. And it's very clear that those organizations, because they have a vested interest in the community, have the ability to make some very significant improvements and changes in the communities as well. And so they were very good examples for why we wanted to start the Berks Alliance, which is, as John mentioned, the anchor institutions here in Berks County, the hospitals, the educational institutions, and a number of the large employers that are really grounded here, trying to produce what we call shared value, getting something that's an improved community, but also benefits them either directly or indirectly. So with that, I want to introduce our first presenter from the Federal Reserve Bank. Eileen has done significant research on this topic, and it's very interesting. I think it will stimulate some of the conversation. So I want to welcome Eileen DeVingry. I said it wrong, didn't I?
DeVringhi, it was very close.
Yeah. Who is the Community Development Specialist for the Federal Reserve Bank of Philadelphia. She has presented to us before, and she's a good friend and ally. So Eileen, you are on, we'll give you the screen.
Great, thanks. I'm going to put a link to the full report that I'm talking about today in the chat in case anyone wants to look at that in more depth. And then I will get my slides up. All right, as Dave mentioned, I'm Eileen DeVringhi. I'm a community development research specialist at the Federal Reserve Bank of Philadelphia. The research I'm going to share today looks at how much nonprofit hospitals are investing in what we consider kind of community development related activities, and as well kind of what activities, what related activities that they are undertaking. And we were motivated to do this research because we were hearing a lot from stakeholders in the community that they were really interested in working with healthcare institutions, but they didn't really have a great sense of kind of where to start those conversations. So they didn't know how much these institutions were investing in this kind of programming or what kind of like priority areas that they were looking to. So our hope is that this research can kind of help fill the gaps in that conversation and make them more productive. So before I get into the research, I'm always required to give this disclaimer whenever I do a public presentation, but these views are mine and not necessarily those of the Federal Reserve Bank of Philadelphia or the Federal Reserve System. So with that out of the way, I wanted to start with a really quick intro to why hospitals might be interested in sort of this community development type work. Because I know for a lot of people, it kind of might seem like it's outside of the scope of sort of traditional medical service provision, things like that. And the biggest reason is that really the vast majority of opportunities to improve health outcomes take place outside of a traditional clinical setting. So research looking at kind of the modifiable factors that affect health outcomes. So taking into consideration that there's variation in sort of natural predisposition toward different illnesses. But looking at those modifiable factors, they found that about 50% of the variation in healthcare outcomes comes from social, environmental, and physical environment factors. So sort of the community context that a person lives in. And then another 30% of outcomes are attributable to things like health behaviors, which can be really influenced by that social, economic, and environmental context. And that leaves about 20% that's specific to clinical care, which is of course extremely important and you know, arguably what hospitals specialize in. But if we're looking sort of at the biggest opportunities to improve health, a lot of them are really related to these kind of more community-oriented programming. And then lastly, you know, I want to mention that I think the COVID pandemic really elevated for a lot of people how clearly kind of economic and racial disparities can drive a lot of these disparities in health outcomes. So we saw things like how housing insecurity, overrepresentation in low-wage service work, lack of access to paid sick leave really affected people's ability to kind of prevent exposure to the virus and kind of keep themselves and their families safe. So these environmental and social contexts really do matter for health outcomes. So I'm going to provide a very brief background on hospital community benefits requirements and kind of related reporting. It gets a little bit in the weeds, but please bear with me because I think it is really important for understanding the findings of our report. And hopefully it'll spare some of this burden for some of the later presenters so they don't have to cover the same ground. So to start with, hospitals, nonprofit hospitals are sort of asked to justify their tax-exempt status by demonstrating that they provide a public benefit that's sort of beyond what a for-profit hospital would provide. And those are sometimes broadly referred to as community benefits. Interestingly, the IRS does not have any sort of minimum standard in terms of expenditures for how much hospitals need to spend on these activities in order to maintain their tax-exempt status. So when you look across different hospitals and healthcare systems, you'll see pretty dramatic variation in how much they're spending. On top of that, for a long time, these requirements were sort of relatively vague, relatively nebulous, but starting in 2009, the IRS imposed much more comprehensive reporting requirements around this. So hospitals are now required to report expenditures on their community benefits on their 990 filings. And those expenditures are broken out into kind of three broad categories. So the first category is also called community benefits, which I realize is a little bit confusing because sometimes that's used to refer as like kind of an umbrella term for all of the spending. But a lot of times when people talk about community benefits, they're talking specifically about spending that's reported on Part 1 of their Schedule H form. And this is, I'll show you the kind of specific activities that are included under this on the next slide, but this is a lot of kind of what you typically think of as hospitals activities. So like charity care, subsidized health services, things like that. Part 2 is community building. And unlike Part 1, which is required for hospitals to fill out, Part 2 is optional. So it gets a little bit less attention in a lot of research and policy. But when you look at what the kind of definition of the community building category is, it's efforts that improve the capacity of local communities to address both individual medical needs, but also sort of these non-medical determinants of health. So it's a lot more aligned with kind of what we think of as kind of the community development sector's core activities. And because of that, that's really the focus of our analysis today. I'll just reiterate that, you know, Part 1 is also very important, and I'm sure you'll hear more about kind of the things that are included in that category from some of the other speakers today, but our analysis focuses very specifically on kind of these part 2 community building activities. The other major important reporting change that I want to note is that as part of the Affordable Care Act, hospitals are now kind of required to do these periodic community health needs assessments where they do some community engagement and crunch some numbers to try to identify what are kind of the top health priorities for their service areas. And so the IRS since 2012 has required hospitals to provide sort of narrative descriptions both of how they developed their community health needs assessment, but also the steps they've taken to sort of address the priorities that they identified. So we have those kind of narrative descriptions as well. So we can get a better sense of like specifically what kinds of activities hospitals are doing that might be of interest to the community development field. So here's the breakout of what goes under this kind of part 1 and part 2 community benefit spending. So on the part 1 community benefit side, you'll see things that, as I mentioned, are pretty sort of pretty clearly in the hospital wheelhouse. A lot of them are related to patient care. You also have things like health professionals, education and research, which might be more relevant to hospitals that are affiliated with the university. And then sort of from our perspective, from looking at, what has the most potential overlap with the community development sector, the 2 most kind of relevant categories there are probably community health improvement services and cash and in-kind contributions to community groups. And even though the potential overlap there is high, I'll say most of these are probably going towards kind of more medically oriented programming still. So right now, probably a lot of it is going to immunization campaigns, but also things like operating capital for community clinics and things like that. So on the part 2 community building side, you'll see things that are kind of much more clearly in the community development wheelhouse. So things like housing, economic development, things that are place-based, things that are addressing kind of non-medical determinants of health, policy development, coalition building, things like that. So as I've alluded to, basically all the data that I'm going to present today comes from hospitals' 990 filings. We're including both the expenditure data in the categories that I broke out on the previous slide, but also sort of combing through the narrative data specifically for the 3 states that the Philly Fed serves. So that's Pennsylvania, New Jersey, and Delaware. So we'll be pulling kind of specific examples of what hospitals are doing from there. One thing to note is that the most recent available data when we were doing this analysis was up to tax year 2016, which sort of depending on the institution can include part of 2017, but is still sort of a specific time period. And we report things in terms of annual averages kind of during that period. And then another thing to note is that hospitals' service areas, we sort of consider to be the county in which the hospital is located. So that's how we do sort of our calculations when we look at sort of the more regional level. All right, so that's all the background. Thank you for bearing with me. Now we can actually get into the results. So I mentioned that we're more interested in the community building, the kind of part 2 expenditures, but I do think it's important to provide a little bit of context on the part 1 community benefits expenditures just to get us started. One thing to note is during this period, hospitals in aggregate spent about $67.9 billion per year on community benefits. As a pretty substantial sum of money. But as you can see from this chart, almost all of, or the vast majority of that, over 70%, went towards kind of patient care activities. So care that's not fully reimbursed by Medicaid, charity care, and then subsidized health services that might not otherwise be available in a community. Really important, obviously like very central to hospitals' missions, but less interesting, I think, to our kind of community development emphasis. And when you look at the categories that are a little bit more aligned with community programming, it's about just about 7% of the spending went towards those categories, and that translates to about $4.7 billion a year. So still a pretty substantial sum. So transitioning to looking more specifically at those part 2 spending categories, which we do think have kind of the greatest potential overlap with the community development sector. One thing that's useful to note kind of from the start is that while almost all hospitals report some community, like Part 1 community benefit spending, because they are in a sense required to by the IRS, about 60% of hospitals report any community building spending. So whether or not you think that's a high or low number sort of depends on your perspective. So on the one hand, hospitals are not strictly required to do this kind of spending. On the other hand, we know that there's a lot of opportunities to improve health outcomes with these kinds of activities. So the average annual spending across all hospitals during this period for community building was $474 million, so a million with an M, not quite in the same kind of funding ballpark as the community benefits spending. And then among hospitals that reported community building spending, on average, they spent about $270,000 a year. Larger hospitals, sort of unsurprisingly, are more likely to report the spending and more likely to spend more on it when they do. And then interestingly, standalone hospitals in comparison to hospitals that are part of sort of a larger healthcare system were somewhat less likely to do this kind of spending, but when they did it, they spent more on average kind of per facility. And so next we'll look at sort of how this breaks out based on hospitals' location characteristics. So we do find that rural hospitals are less likely to report this kind of spending, and when they do, they tend to spend less per facility, which makes sense because these tend to be kind of smaller hospitals. And then if you look at this kind of broken out by county poverty levels, interestingly, the highest poverty counties, the hospitals tend to be less likely to report this kind of spending, but in terms of how much they're spending when they do, it's sort of more of a mixed bag. And then this is just, again, sort of a national overview of how spending breaks out between all those different community building subcategories. And we can see that there are certain categories that are much more likely to be funded than others. More than 2/3 of the aggregate spending during this time went to the categories of community support, workforce development, or community health improvement advocacy. By contrast, less than 1/5 of the spending went towards the kind of more place-based, like kind of core community development activities of housing improvements and economic development. All right, so that was the big kind of national overview, but fortunately we're also able to kind of drill down and look more specifically at community building spending in our region and similar regions kind of throughout the state. But first, let's get started and sort of look at the variation by state. So this is community building spending per capita. So we're accounting for the fact that there's a lot of variation in population across states. But what we see is that there's a pretty dramatic range of how much hospitals are spending on these kinds of activities in different states. So it ranges from about 3 cents per capita in Rhode Island to more than $8 per capita in Delaware. And to some extent, this is going to be driven by, where there are lots of hospitals and like large hospital systems and things like that. But it is interesting to see such a wide range. And then looking specifically at Pennsylvania, you can see that we're sort of on the lower end of that range with about $1.36 per capita in community development spending by Pennsylvania hospitals. So zooming in even further, this is the aggregate spending on community building for small to medium-sized metropolitan areas in Pennsylvania. I've left out Philadelphia and Pittsburgh since they're sort of outliers in terms of population and just kind of this presence of healthcare systems there. But even within this set of metro areas, you can see that there is a really wide variation. And again, this is aggregate spending. So this is not adjusted necessarily by population or like number of facilities, but you can, just to get sort of a sense of the scale of the spending, it ranges all the way from about $2 million a year in the Lancaster region, all the way to $0 per year in the Bloomsburg-Berwick region. The Reading region, which is Berks County, is on the lower end. So the average annual spending was about $12,500. So relatively modest in comparison to some of these other metro areas. And then this is the same kind of figure broken out per capita. And you can see Lancaster is still sort of a bit of an outlier at the top there. And then Reading still relatively close to the bottom with about 3 cents per capita in community building spending during our study period. And then I've added back the Pennsylvania statewide average, which you can see is $1.36 per capita. And then here's a breakout of community building spending by category. So comparing what categories hospitals in the Reading region spent or allocated funding towards versus how that funding was allocated statewide. It largely aligns with what are the most kind of common categories statewide, but it's worth noting that the majority of the community building spending by Reading area hospitals went towards community support, which is defined as it can be violence prevention programs, grants to community organizations, subsidized childcare. Like there's kind of a range of sort of community-based programming that kind of funding goes to support. By contrast, there wasn't as much, or there wasn't any spending allocated towards kind of the more core community development categories of economic development and physical improvements and housing, which is consistent with what we see statewide. Those are just sort of less funded categories generally, and do tend to be sort of bigger ticket investments. So now I'm going to go through some examples from our analysis of the narrative reports of how what hospitals were doing sort of in alignment with the community development sector during our study period. So as I mentioned earlier, all of these examples are going to be from 3 states that are included in the Philadelphia Feds District. So they'll be kind of more or less in our region. Yeah, all of them are pulled from those narrative reports on the 990 form. So they can give you a more kind of specific example of what kinds of things these programs, the spending went towards. Granted, these are not reported in the same categories that the spending is. So we had to have a kind of different strategy for categorizing the programs and interventions that we looked at. And so we decided to categorize them by kind of the underlying social determinant of health that they were designed to address. And then we also kind of further identified whether or not they were kind of patient-based, so designed to respond to like an individual's kind of social health needs versus kind of community-based. So were they responsive to kind of community conditions that we know sort of influence health outcomes. So that distinction is in there as well. So we'll start with the community and social context theme. So this includes things like financial and in-kind support for community-based organizations, community programming, and local capacity building. The example that we cited here is from a hospital that partnered with a local library to provide kind of a community resource and connection hub to people who live in an area that's a little bit remote from kind of the core city. Next, we have the economic stability theme, which encompasses issues related to employment, income sufficiency, and financial health. So this first set of interventions is really focused on that kind of financial health piece. But these are all interventions that would address like financial stressors and connect people with kind of needed income supports. And so the example we provide here is a hospital that partnered with a legal aid group to have somebody on site to help people enroll in kind of benefits programs that they may be struggling to access, or do or provide other sorts of legal supports that they might need to address things that might be immediate concerns in their lives. So also on the economic stability theme, a lot of the interventions kind of focused on hospitals' role as a major employer, a major purchaser, and sort of the important presence they have in a lot of regional economies. So in the example cited here, this hospital partnered with a labor organization and the Workforce Development Agency in their region to develop a program that trained kind of local workers to fill high demand healthcare positions. And then moving on to the education theme, which encompasses everything from pre-K to kind of adult education and vocational training. The example we've included here is from a hospital that partnered with the local school district to kind of support wraparound services for preschool students and their families in sort of a low income area of New Jersey. And then next we'll look at some of the hospital interventions that were designed to address sort of food security, access to healthy foods. And this was a very commonly kind of reported area for a lot of hospitals just because of the kind of strong link between diet and health outcomes. But the example we have here is a hospital that provided a grant to an urban farming organization so that they could have a cold storage facility to help them store more produce and be able to make that produce more available within the community. The next category is related to like the healthcare system, and a lot of these interventions were focused on improving access to clinical care by sort of going outside the four walls of the hospital, but also by doing kind of targeted outreach to medically underserved communities or communities that just have difficulty connecting with those services. And so the example that we've included here is of a hospital that worked with faith communities that may already have sort of existing relationships and built trust in with certain kind of medically served underpopulations. And it kind of focused on building their capacity to connect their congregants to needed kind of medical care. And then our last theme is the neighborhood and physical environment theme, which is, again, very central to sort of what we think of as the traditional community development activities. It encompasses issues related to housing, access to the kinds of amenities that help people live kind of healthy lifestyles, and also sort of the quality of the built environment. And so this example here is from a hospital that worked with the community organizations in sort of adjacent neighborhoods to construct a park and then sort of agree to continue the kind of maintenance and upkeep of that park. And then our last example here is from hospital interventions that focused around kind of housing security. So a lot of hospitals expressed interest in addressing kind of chronic homelessness just because that's associated with some really costly sort of health outcomes. And so a number of hospitals were really interested in addressing that challenge. And the example we provide here is a hospital that was doing sort of capacity building and early funding around a housing first program in their service area. So this was a very abridged overview. There's a lot more examples in the report. I'll put the link to the report in the chat once again, because I think a lot of people probably joined after I initially put it in the chat. So yeah, there's lots of examples in the report. I encourage you to check it out and see sort of what aligns with maybe what your organization is focused on. And so just to kind of recap the main findings, so community building expenditures by Reading area hospitals was pretty modest during our study period. Again, this is sort of a separate question from the community benefits overall, which includes kind of our traditional charity care, financial assistance, but really focusing in on the kind of community development oriented spending. So it was relatively modest, averaging about $12,500 a year, mostly went towards the category of community support. We didn't necessarily see interventions related to, or spending rather, related to housing and economic development, which are things that I think a lot of organizations in the community development space tend to connect with a little bit more. And then lastly, bringing it back to the pandemic and how it's sort of changed this context, it's both highlighted how important a lot of social determinants are, but it's also been such an enormous kind of financial disruptor for a lot of healthcare systems. And so I think in the near future, sort of looking at these kinds of initiatives, it's probably going to take a lot of partnership and collaboration to really like leverage resources to be kind of their most effective. And so that covers my presentation. I'm happy to take any questions. And like I said, I'll put a link to the report in the chat again. And then I think I am passing things back to Dave.
Yes, thank you. Eileen, great job. Very interesting stuff. If you have questions for Eileen, please submit them on the chat function. I've already submitted a couple of mine and I probably have about a dozen more to go. We are lucky in Berks County to have two very significant health systems here in the county, one of which is Tower Health Reading Hospital, and the other is St. Joe's Medical Center, which is part of the Penn State Health System. And we know that both of these organizations have been very actively involved, increasingly actively involved in the community. So we've asked them to do brief presentations about what they're doing, how they're engaging and helping support community development. We're first going to hear from Tanika Mason. Let me go back to my notes here. Tanika is the data manager for community wellness for Tower Health. So Tanika, to you.
Thank you, Jay. Thank you. Okay, let me get my screen pulled up here. And if you all can just confirm that you're seeing my screen, and then I'll go ahead and get started. All right, so my name is Tanika Mason. I'm the data manager in the Community Wellness Department at Reading Hospital, and it's a pleasure to be with you all this afternoon and talk about how Reading Hospital is an anchor institution in the community. Today I'll share with you not only how much we spend in community benefit contribution, Tanika, but most important, yes.
We're getting a little bit of breakup in your talk, so I don't know whether you need to be closer to the mics or whatever, but sorry, didn't mean to interrupt.
Okay. No, it's okay.
Much better.
This is better? Okay, it's better. All right, maybe I need to be a little closer. Okay. So not only showing today how much we spend, but most importantly, how we really contribute to the community and building up the community in efforts to achieve a higher quality of life, better access to care and to services. So I wanted to start with a brief definition of community benefit. So this is one of, as Eileen mentioned in her presentation, and when you read her documentation, you'll see community benefit has a very broad definition stated by the IRS. And as Eileen mentioned, it doesn't tell hospitals how much they have to spend. It doesn't say if it's tied to growth revenue. So it's really up to the hospital to define for themselves what is community benefit, what does that mean, and what will we do to contribute to that. At a minimum, just to be compliant to adhere to your tax exempt requirements, hospitals just have to provide financial assistance and charity care. So anything hospitals do above that is extra. So at Reading Hospital, we have a department that is dedicated to doing this work. So that really sets us apart from a lot of other institutions and really adds to our uniqueness. So if you all know, and I'm sure you know, when you get extra work on your desk, there's slim chances to tremendous success. However, with full-time employees who are dedicated to doing this work, it really, really contributes and adds to our success there. So the Community Wellness Department is geared to improving the health and wellness of Berks County residents, and we do that pretty much through a community health needs assessment. It's really the foundation of the work, and it really helps us to identify, what are the community needs, and then to brainstorm and even pull from some best practices. So we're not necessarily recreating the wheel, but really looking for those initiatives that are in good response to those needs. And I'll talk a little bit more about the community health needs assessment and how we really use that to tie to our community benefit in a couple of slides. So I wanted to share this pyramid. And if you remember in the first slide when I shared the community benefit definition, so at the bottom of the pyramid at compliance only, a lot of institutions, healthcare institutions and hospitals can sit there, right? That's the financial assistance and the charity care. However, at Reading Hospital, we really are moving towards the top, right, in that second generation, this area of the pyramid. We have a number of services and initiatives, and I'll speak to more details on some of those that really set us here, where we're collaborating with multiple organizations across multiple sectors so that we could drive some of that work and see some of that success that's really, really impacting community and member lives. So it's really about being intentional with the funds, you know, where are they going? What's the impact? How are they being spent? What is the why? Those are all necessary and critical components that are considered when we're looking at and doing the CHNA, rolling out and implementing community programming. So in a couple of slides, I'm going to show and go into details on some of those programming. Before we get there, though, I wanted to just share with you all just the how much we're spending. And I have a couple points to share on this slide, and then a couple of implications that I also want to share with you that Eileen so graciously mentioned. So take some of the hard explaining off on us. So this is showing us our Reading Hospital's community benefit spend for fiscal year 2019 and 2020. So if you look in the second line item, community health improvement services, you'll see a decline from fiscal year 19 to 20. That was in large part due to COVID. So a lot of our community programs are people facing. And so because of COVID, a lot of those had to just were idle for some time. And we also had some internal changes that we dealt with at the hospital, and so some of that was reflected in the net spend between those two fiscal years. Jump to the next line item, health professions education. You'll see a large bump up there. And that was really a large part to an expense that was previously unaccounted for. That we discovered. And I'll talk a little bit about those implications because that is common around a lot of hospitals when doing this work and when going to report it on the 990. This last line item here, cash and in-kind contributions, you'll see a significant decline there. And if you all remember in the news not too long ago, Reading Hospital Tower Health has a joint venture with UPMC. And so one of the stipulations of that was that UPMC has the first right of refusal for sponsorships. So a lot of the sponsorships that we were previously funding prior to that joint venture were then picked up by UPMC, and so it wouldn't be reflected in the community benefit contribution for that year. Lastly on this slide, you'll see just called out for fiscal year 2020, our COVID expenses, and most of that was salaries and wages. However, we did spend a good amount on vaccine rollout, education, and all the things that really go into rolling out community-wide vaccine. So on this next slide here, really talking about some of the implications. So tracking, reporting, and funding are one of the largest implications to consider when taking a look at a hospital's community benefit contribution, and also as the hospital reporting that and adhering to your contribution. So after the Accountable Care Act, our next cycle, we had actually revised our reporting. So that actually occurred in 2016. So as you look at the report from Eileen, some of those numbers are then would then be not as accurate, and that was because of a tracking reporting flaw that has since been revised by the hospital in 2016. But then also there's some coordination issues, and I think this is common at other hospitals as well and other healthcare entities, because you always have physicians in small groups around the hospital that might identify their own gaps, their own challenges, and might come up with their own programming and their own grants. And so a lot of the times there's programming and there's services that go unreported to the IRS. And so there's a need to look internally, especially to ensure that we're capturing all of our programs. And so those information is being actually submitted to the IRS on our community benefit contribution reports. And then tied with that coordination is also a data system. So most recently, we started using Sabisa, which is a community benefit inventory data system, so that we can track and keep and then look at our community benefit activities. And prior to using that system, we were doing it on a Microsoft Excel spreadsheet. And if you can imagine the human errors that can occur with that, and if you can couple that with the coordination issues, you can see how some of the reports just don't make it. And so those are just implications just to consider as you're looking at that. And then lastly, funding. So a lot of almost all of our programming and services have all derived out of grants. And so the IRS they don't look at that. They're looking at hospital operations and not grant funding. And so if you, in the past couple of years, we've actually secured up to $9 million in grant funding. So if you add 9 million to this numbers on the last slide, that'll give you a more true and accurate picture of the net spend Reading Hospital and Tower Health is providing to the community. So I just wanted to point out those things there. And then of course, as I mentioned in the last slide, even certain things are where's the money coming from? So because the money for sponsorships are coming for UPMC joint venture, it wouldn't be reported then on our 990. So the community health needs assessment, I mentioned this early. How do we know what the community needs are, and how do we know what we can and can't do? So throughout the community health needs assessment cycle, we collect data both primary and secondary. We do a host of key informant interviews, focus groups, stakeholder interviews and engagements so that we can identify really what are those issues and what are the needs of the community. And then we bring those same groups back together and present that data back. So here's what we heard you say. And now let's think about this as a group. What is feasible for the hospital to take on? This is something that we can do, but what can this group, this community, this clinical and this community group as a network together, what can we do? So the key there is really staying within your wheelhouse. And I'll give you 2 examples. So in, I believe it was the 2016 CHNA, dental health was the major priority, a major health need. However, Reading Hospital we weren't in the wheelhouse to do that, right? So certain times we have to take a step back and really build up who's with us, who is really best suited in that line of expertise. So out of that community health needs assessment, the Berks County Oral Health Task Force came about. Again, it wasn't our expertise, but we still committed and dedicated staff time to that group. Another example is the Berks Teens Matter. In another previous health needs assessment, we've seen a lot of the pregnancy and high school and teenage pregnancy. And again, it wasn't something that the hospital can necessarily lead, but we can definitely support and collaborate with our community partners. And so we continue to do that. So with our community health needs assessment and our implementation plan, we really take a look at that intentionally. We're looking at what programs can we fund. There's some that we can fund, there's some that we can partner and collaborate with, and there might be some that we can, and there might be some that we can lead. And so we're okay with definitely being able to take that back seat when needed. So I'm going to get into some of the different programs and initiatives that we implement and set out for the community. So these 4 areas are actually the 4 priority areas from our last CHNA cycle. And I just called out just 1 or 2 of each programs that were in response to those priority areas. So in access to healthcare, like Eileen noted, the homeless population tends to drive up a lot of poor health outcomes, expenditures, and the like. And so the Street Medicine program has provided primary care to homeless individuals in various locations. We do this at our local shelters like Hope Rescue Mission, a New Journey Community Outreach Center, even some of the tent sites as well. And we've served 1,200 patients to date. With workforce development, here's another good one that's building up community. So we have various different programmings, internships, shadowing experience and observations. With our high school internship program, that actually started in 2014 to 2015. And it started with just Reading High School students. A year or two later, we expanded to add Wilson High School students. And we've had 50 students participate thus far. 2 of them have completed nursing school. We have several who are currently employed at Reading Hospital. And then we also have some other college interns who are helping with one of our social determinant health programs. That high school internship program was actually funded by a local business owner. So here's another program that might show up on a narrative, but not necessarily on the expense and 990 expense form. And so if you think about, what that does for an individual, but really what that does for a family and a household and a community, it just continues to drive upstream. With our disease prevention and management, we do various health screenings. Those are all in preventative care. So that might be your second tier on that pyramid that I showed. With access to food, we've partnered with Helping Harvest. We have a system called Healthify. We have various community organizations who are using that, receiving referrals for patients that have needs in housing, food, transportation, utilities. And with access to food, we've done focus groups, stakeholder interviews, data sharing and collaboration, and really the work just continues to move on there. In the social determinants of health category, as I mentioned, I allude to the Community Health Project a lot, Community Connections Project a lot, where we're screening patients for social determinants of health and connecting them to community organizations who can address those needs. And with our medical legal partnership, we have an attorney that is addressing legal issues and a lot of housing habitability issues as well. And I'll talk a little bit towards the end of my slides about the MLP, because we're really hoping that with that program, it'll push us to the tip of that pyramid to really influence policy and change some policy there. Lastly, on this slide, our access to behavioral health programs. So for mental health screenings, actually a year right before COVID, the onset of COVID, we worked with DCC to put on mental health first aid trainings that was provided not just for Reading Hospital employees, but it was also open to community members as well. And then through our Center of Excellence program addressing the opioid use disorders, that was another program that would show up in the narrative as well. But without that program, we wouldn't be able to get those needed to care in a timely manner. And so it was really imperative that we take that program on. And so it's just more on that community benefit and building. With our CCP, the Community Connection Consortium, we have about 30 or more clinical hospital staff, also community service partners. We'll have payers at the table, local government at the table. We meet on a bi-monthly basis, sharing data, talking about building capacity to address patients' social determinants of health needs and close community gaps. We also have our Diversity and Inclusion Council, who's taken a real keen look at cultural competency, at the hospital. This really ties into how that really trickles out of the hospital walls. How can we be a more diverse hospital system at our leadership levels all throughout? Even as Eileen was mentioning, what are other ways in human resources, workforce development, taking a look at who we're recruiting, who we're retaining, things of that nature, and educating our staff. So when we talk with patients, that culture and that culture is shown out. Food access, I talked a little bit about that on the last slide, so I'll just move to transportation. Transportation was a great need that we have identified through our SDOH programming, and we were able to partner with BARDA. They use a Healthify system as well, and we were able to conduct a transportation education workshop that was not just for Reading Hospital staff, also for the community as well. And so that as community members are referring patients and helping patients and community members, they know who works at BARDA and they can get those answers for them, and they can understand the programs and eligibility so that they're able to better serve the public at large. And I would be remiss to not showcase and just thank our many different partners. And here's a host of partners that are utilizing our health advice system to respond to referrals. And we partner with many of these community organizations on various other projects and initiatives, not just the Community Connection Project, but just definitely a slide to dedicate to them. Without these community partnerships, it would be very difficult to not just benefit the community, but to build it out. So thank you there. I'm going to be wrapping up soon with how we measure success. So we have a community benefit committee who actually is providing oversight and compliance evaluation and review of our community benefit spend and the activities that come out of that. As I mentioned throughout the presentation, the community health needs assessment and that implementation plan. So the implementation plan has very specific goals. And so by looking at that plan each cycle, we can keep ourselves accountable and ensure that we're adhering to the goals that we stated and pivot if we ever need to. All of our community wellness program are all tied to programmatic outcomes. And we're really looking at how are we closing those access gaps, those barriers and those community gaps. So looking at those more longer term impacts, not just the short term ones. And then patient success, especially through our MLP program, is really helping to restore that empowerment of the patient. When we first brought on our attorney, we had a patient with some needs in the house, and all the attorney had to do was leave a voicemail on the landlord's phone. And that next day, the landlord was helping that patient out. So, these are really instances of, small, what we might think of small to hire an attorney, but you can see the longer term impacts it's having, not just for the patient's individual, for the family, for the household, and for the community at large. And then creating those pipeline programming. Dave mentioned earlier, Eileen mentioned earlier, I think everyone mentioned about, providing and having jobs with livable wages. So we're creating these bridges to employment with the hospital in multidisciplinary ways, maybe untraditional ways, getting some new people in the door, right? So we can add to that culture and that diversity and just keep strategizing and looking for success. And lastly, how are we moving forward? So our last community health needs assessment cycle really had themes around social determinants of health. People had a hard time getting to appointments, getting to fresh food, understanding how to use their fresh food, going to pantries, things like that. And in this cycle, our current theme that we continue to hear is health equity. And so how can we take a front seat on improving health equity? And it will be to continue a lot of those programs, especially the social determinants of health program. So we'll continue to create and to have collaboration with community partners in various sectors, always looking and welcoming those introductions and those partnerships. And we'll continue to roll out our social determinants of health program, standing up Healthify as a coordinate network, as a resource for partners in our coordinate network, and taking a keen look at diversity and inclusion as well. And how does that impact some of the things that we can do as an anchor, as Eileen mentioned, like things like supply and human resources. And then our medical legal partnership. So lead has been driving up and up as a community need. What can we do with our legal resources to help drive lead abatement programs and utilize data that we have to drive and get those grants as well? And then lastly, funding sources. As I mentioned, we've got $9 million to date in grants. We have local business owners and other private funders who help to stand up some of these programming. And so we'll continue to look for that, but we'll continue to look for other avenues of where we can have sustainable funding. And that might be through some of our insurance payers, and of course, through our hospital operation costs as well. So with that, I hope that, I've enlightened you all to some of the work that the Reading Hospital is doing, and just to make a mention that we will definitely help our sister hospitals to stand up their program as we lead their CHNA. And I will turn it over to Dave. Thank you.
Great, thank you, Tanika, very good job. Lots of good and interesting information, and some questions that have surfaced and a lot of good conversation that's been going on in the chat box about different things. So thank you very much. We're going to move on to Jim Bennett, who is the VP and COO of Penn State Health St. Joe's, and I think he's going to be joined by a couple of colleagues. So Jim, to you.
Thank you, Dave. And I want to thank Tanika Mason. You know, I was preparing to present to this group today, and then I heard Tanika was going to present, so I called in some backup. So I'll have Lisa Weaver and Laura Welliver joining me on some particular efforts that we've put into place at our downtown campus. But before I do, I'm going to go off script here a little bit. I want to share something that was posted in one of our hallways in our hospital. I'm going to step away from the screen because I'm reading from a 2 feet by 3 foot banner of, imagine something like the Magna Carta, like old paper with very, very interesting calligraphy on it. So here's what it reads. At a meeting of the Board of Health of the City of Reading, Pennsylvania, held October 30th, 1893, the following resolutions were unanimously adopted. Whereas, when the epidemic of smallpox broke out in this city last spring, and the health authorities found themselves without any suitable hospital accommodations for the afflicted, and whereas promptly the doors of St. Joseph Hospital cheerfully and charitably were thrown open, Reverend Father Borneman and the Noble Sisters of St. Francis volunteered to receive the afflicted. Whereas during the summer and fall, in the duration of a loathsome epidemic disease, numbering over 500 victims, a large number have been received, nursed, and discharged as cured at St. Joseph's Hospital. I just think that's so cool. I mean, that is part of our DNA here at St. Joseph Hospital, dating back to 1893, so 147 years. And so being part of this discussion today and sharing that document with you, it just speaks to how long we have committed to being part of the Reading city, the Reading hospital, the Reading community. And again, you know, Tanika Mason and the Tower Health System, they are strong advocates for the community and the benefits of the folks that seek our services. And so here we are. This is our downtown campus, 6th and Walnut. You can see we house Haven Behavioral Health there, among other services, including some dental work that Tanika had mentioned. We also have some of our residents down there doing some family and internal medicine care for our underserved folks in the community. Next slide. Herein lies the Penn State Health System's commitment to what Eileen was presenting to us today in her research. You know, as a health system, we understand that the better we are at promoting health and wellness and preventing disease from starting in the first place, the better our health system and greater economy of our city is. And so Penn State University sits at the top, helping us guide some of our funding and resources, which, as we all know, is critically important. The College of Medicine and here in Penn State Berks all work together to serve St. Joseph's Medical Center here in Berne Township. Next slide, please. As you can see on a small map, we started downtown on 12th and Walnut. So the original hospital has is the you know, the tower there, the cathedral with the bell tower. And we decided to close that building and donate that to the Reading School District. But right down the street was this community hospital, which was a picture of what I shared with you on 6th and Walnut. Inside this hospital, of course, are other health and community services, one of which being this incredible simulation center that we use to bring in healthcare providers to work on, you know, CPR or other kinds of critical skill sets that are necessary for care at the bedside. And of course, if you haven't seen it, it's in my background here. This is the Berne Township St. Joe's Medical Center. We are 208 beds. We're very proud of the work we have accomplished, but we're particularly proud of what we've recently invested in. As Penn State Health has become part of our system, we've been the beneficiary of lots of capital investment, not only in our brick and mortar here, but in the care delivered in the downtown campus. Money is carved out just for the downtown campus and all of what we do, knowing that that's our biggest return on investment for the benefit of the community. And as you can see here in our diagram, now this, as you see, this isn't generated by Penn State Health, but the credit is below. We can see that social determinants of health, socioeconomic factors, physical environment, and health behaviors contribute to more than sickness of the patient, right? So this again speaks to the work that Eileen's done on helping us as hospitals and healthcare systems identify where we can make the most impact on the community that we serve. The Penn State Health System also uses the community needs assessment to drive what do we focus on? How do we get there? And like Tanika's group, we have objective measures. We want to make sure that, hey, how well are we doing? What did we miss? You know, what Tanika presented today is very much what we do as well. We have the community buy-in. We survey the folks who, like yourselves, the audience here today. What are you seeing in your work environment? What are you seeing as you serve the community? We gather that information. We have large group discussions. We then send out surveys, and then we collate that data. We present it back to the community and those folks who presented us with their concerns. And then we kind of determine through the feedback of these think tanks, small group discussions, what are our priorities for 2021? So what you're seeing in front of you today is our 2018 drill down. And right now we're literally in the middle of the process of determining what is our focus for the next 3 years. Next slide. Another illustration here of how Penn State University, Penn State Health, and Penn State St. Joseph are working together inside the community here. The Invent Penn State Coalition has formed and morphed into a Reading-centric launch box. Lisa Weaver is particularly interested in that. She's our leader with working on some of our innovative ideas to serve the community. So entrepreneurial spirit, looking at ways to serve the needs of the community, not make money for, software programming or such, but in fact, what can we do as entrepreneurs to serve the underserved community here? Next slide. I don't think we could talk about social determinants of need without mentioning the COVID pandemic. What's particularly interesting to me is in the start of today's presentation by me reading this meeting of the Board of Health in the city of Reading, Pennsylvania, they mentioned smallpox. We all know that smallpox was the pandemic that COVID was compared to as we prepared to prevent the spread, to develop an immunization. And St. Joe's was a beacon of light for many folks in the community as both as care for the sick, in testing, and now we're in the process of immunizing thousands and thousands of community residents in Berks County. Our last count is we've delivered at least 75,000 immunizations, contributing to an overall immunization rate in the county of Berks, in Berks County at 53%, and that county part of Pennsylvania up to 56%. So we're very proud of that work. And we've even worked with Tanika and her group where literally they had some, they had some extra patients that needed some immunizations. They gave us a call or, hey, where are you getting your supplies? Because we're down. This is the kind of work getting done behind the scenes that isn't necessarily conveyed in some of the slides here. Next slide. And like the Tower Health Group, we're very proud of the partnerships we've formed with the groups you see before you. This is a sampling of some of the folks that have partnered with Penn State Health, the downtown campus. I imagine some of you in our audience have also worked very closely with us, and you may not be mentioned in the business signage here, but know that we're very, very thankful for all the things that you're doing to help us meet the needs of the underserved community. And at this point, I'm going to hand it over to Laura Welliver.
Good afternoon. Thanks, Jim. I'm Laura Welliver. I'm the Grants and Special Projects Officer for the hospital, and I work closely with Lisa Weaver and others on our Healthy Community initiatives. We don't have a specific department or designated staff yet for some of these, but we have key partners around the hospital and around the health system, working with our colleagues in Hershey in particular. And they've given us a great deal of help and expertise. I wanted to just echo a couple things that were said about the CHNAs. Somebody asked a question in the chat, and yes, we actually did work with Tower Health on our first couple and several other key organizations, including the Community Foundation and the United Way, on our first couple of CHNAs. And then as Tower Health grew and St. Joe's became part of Penn State Health, we branched off into doing the process in a little different way. But we still keep in close contact because it's very important that we're working in tandem. And yes, dating back, I think the health landscape has changed a great deal since 2016. And there's a lot of things that perhaps weren't counted or weren't counted accurately in some of the old data. Hopefully we've impressed Eileen a little bit with some of the things we're doing, and our numbers will start looking better in the larger scheme of things. When I first came to St. Joe's, I actually came to work specifically on a violence prevention initiative, and we worked on youth violence specifically here for several years. More recently, under the umbrella of the Lang and Allied Health Academy, which has evolved, the programs and partnerships of that initiative have evolved over the years to work on language, literacy, and workforce development and education and training needs. And I wanted to give a quick shout out to our original partners in the Allied Health Academy initiative, which were the Hispanic Center, where I actually worked at the time, and also Kutztown University, and really spearheaded by Reading Area Community College. We've had a number of other folks involved since then. And one of our signature programs is our Community Health Worker Training Institute, which has been going for several years before community health workers became the flavor of the month. And we've been doing this for quite some time in partnership with the Area Health Education Center, the AHEC, which developed the original core curriculum, and the Literacy Council of Reading Berks. We are so proud of this initiative, and I'll put some more information in the chat as soon as I can. In case you aren't as familiar with the community health worker model, it is a training model that trains authentic community connectors to help navigate patients and community members through the health system and the human service system. And also, as Jim mentioned earlier, we do have state-of-the-art classrooms here. We've always had some clinical classrooms in the lower level of the Lang and Allied Health Academy here at the downtown campus. But now we have amazing technology available here for clinical simulation. Some of our medical residents come and practice skills here. So it goes all the way from entry-level healthcare professionals up through physicians. we're really proud to be partnering with Penn State Berks on that initiative and lots of other folks in the community. And I think Lisa's going to pick up from here. Is that correct? Yeah.
Hi, everyone. Lisa Weaver, Healthy Community Program Associate with Penn State Health St. Joseph. Can you hear me okay? Great. All right. I'm happy to share with you today a little bit more in detail about some of the programming that we have here related to what we call food as medicine, related to food access and improving nutrition in the city. As Tanika was mentioning, we are able to prioritize the programming that we do according to the community health needs assessments that we conduct about every 3 years. So back in 2016, as Jim showed you, some of the recent health needs priorities that were identified by the recent cycle of the CHNA for us were diabetes and obesity among the top health concerns or priorities for Berks County. So our team began researching some upstream approaches to addressing chronic diet-related illnesses. And we discovered the concept of a produce prescription program. Often clinically based, these are innovative nutrition incentive programs that allow physicians and providers to prescribe, literally prescribe fruits and vegetables to qualifying patients who then redeem the prescriptions at participating retail locations. So in partnership with the United Way, we piloted our own produce prescription program here. We call it VeggieRx back in 2018 at the downtown campus. We officially ran the pilot program for about 14 months, tracking basic biometric data of the patients and general health outcomes. And thanks to multiple community partners, our patients are able to redeem their vouchers, their prescribed vouchers at multiple vendors, including vendors at the Penn Street Farmers Market, which is happening right now as we speak. So the pilot data that you can see in front of you here was very encouraging, specifically the very last point, the average decrease in hemoglobin A1C of 1.3%, so blood sugar levels. And so we're working with researchers at the Penn State College of Medicine to continue researching the long-term health outcomes of programs like this. Surprisingly, there's not as much detailed research going into the efficacy of fruit and vegetable prescription programs at the individual patient level. So we're really excited to be part of some pioneering research in that realm. And then of course, as you can see, the second bullet point there just shows the benefit that these programs have to the larger community in terms of economic development and stimulating the economy, specifically supporting our local ag industry and our vendors, our farmers. So over the course of that time frame, equivalent of over $45,000 was spent on local produce, which is pretty significant. So in parallel with VeggieRx, we decided to launch our own farm stand, our own internal farm stand at the hospital's downtown campus, so patients could redeem their prescribed vouchers on site without having to leave our campus. So since 2018 as well, we've been operating this weekly farm stand in partnership with Blue Mountain Academy. They're a private school in Hamburg. They operate a student-run organic farm, and they sell a variety of their organic produce as well as outsourced tropical produce at our farm stand. And it's open to the public every Tuesday from 11 to 2, so we welcome you to stop by. The vendor, BMA vendor, accepts multiple nutrition incentive currencies as payments, including SNAP, WIC, and the new community currency program that we're working on called the Berks Farm Bucks program. So we're working with the Food Trust and GRCA, our local chamber, to expand that community currency in Reading. So both VeggieRx and the farm stand are part of a larger strategic partnership with Penn State Berks, stemming from the Berks Launchbox initiative to spur economic development, innovation, and job creation in our region. I'm happy to answer any questions about that, and we'll turn it back over to Jim.
Thank you, Laura. Thank you, Lisa. Thank you, Dave and John. You guys are incredible champions and leaders in our community, not just for the Greater Reading Chamber Association, but in other endeavors, and we all know that. And again, thank you, Tanika, for making me better. I knew when you were presenting, I had to show up. So, you know, Lisa and Laura very much helped me with that and what we presented to you today. I sat here and listened to some of the work getting done, and, you know, so much of healthcare as a COO is focused on curing the sick. when you think about the money that goes into the National Institute of Health for research, a fraction of that, if dedicated to health and wellness and the underserving and addressing some of the social determinants of need and looking at Eileen's research to better target our efforts using community health needs assessments, I just imagine what we could do with all of that. So I'm really thrilled to have the opportunity to present to you a small portion of what St. Joe's is doing to serve and benefit the community through the work, again, as Eileen has articulated in hospitals as anchors in the cities that we serve. So with that, I'm going to hand it over to Dave, and I know that we're going to stick around for some questions. So thank you, Dave.
Thank you, Jim. Thank you, presenters. You guys did a great job. It's very impressive. Tanika, sorry they had ganged up on you like that, but we've had a lot of interesting back and forth in the chat function, and feel free to submit some questions. I've got a few here that I wanted to run through. One was answered in part, but I have sort of a take on it. And that was why that both institutions seem to be doing their own community health assessments. There had been a history of doing them together, but there's reasons why to do them separately. But each of you are part of a bigger system that serves much broader geographic area than Berks County. Do the health need assessments focus in a lot on Berks County? Do they drive what you're going to be doing here, or are they driven by that broader network and the broader geographic area that you serve? Anybody want to try to answer?
Jim, do you want to go first?
Tanika, you want to go first, and then I'll hand it off to Lisa. I think she and Laura have a look. I know we do some Berks County and other county assessment, but yeah, please.
Okay, sure. So here at the hospital, at Reading Hospital, the Community Wellness Department actually leads the CHNA cycle for this system. However, Tower Health as a system does conduct community health needs assessments for each hospital service area. So when Reading Hospital is doing their community health needs assessment, it is for Reading and Berks County, Reading, PA, and Berks County. So we get, and I just actually dropped some links in the chat, if any of you are so kind to share this with community members or take it yourself. But we do a host of surveys with members in the Reading and Berks County community so that we can solicit their feedback on what are the needs at Reading and Berks County, and then what we can do as a group of Reading, Berks County organizations together, or what the hospital can take on, as I mentioned. So those needs assessments are targeted. They are targeted to the community.
Yes, similarly, I would say it's both. We do, we collect and provide data that is regional and system-wide as Penn State Health has grown and is going to be, growing again within the next year or two. But we also segment the data that is Berks County specific. And this year, we just completed our survey process and we presented some preliminary results of our community health needs assessment. And we'll be glad to share some of that with this group as soon as it's a little bit more ready. But we are able to kind of do both. And despite the pandemic, which made the survey process a little more challenging, we did get a really good response and a nice representative sample from Berks County. So we think that that you'll be interested in the next steps. And then, of course, with Reading Hospital conducting theirs, we should be able to pull together, they're right on the heels, and we should be able to pull together some nice aggregate information.
Good. Tanika, you mentioned this, but I want to see if we can get a little bit more discussion about it. There have been a series of recent articles about issues of exposure to lead. I know that the data is driven by children, particularly children enrolled in programs like SNAP. But given the old housing stock, particularly in the city and the geographic area around it, Given the fact that Berks County is probably the lead battery capital of the world and has been for a long time, not meaning to cast aspersions on any industry, is that an issue that the two health systems are taking a look at? And what kinds of things could you help the community do to try to address those?
Yeah, so with the lead right now housed with the city of Reading. So there are a number of grant opportunities, like health research grant opportunities and initiative programming. However, the city of Reading is really looks to be more of who's most appropriate to like hold, like, you know, to be the anchor in that issue, right, if you will. However, at Reading Hospital and through our social determinant of health programming, where we're screening patients, we're collecting a lot of the data that can help support drive those initiatives. So we asked about housing habitability, instability and habitability. And so we're able to collect that data and get a better grasp on who and where, right? Because we're getting patient level data. And then, as I mentioned, we have an attorney on staff who's really working more closely with the city of Reading to really help on that front. So I think it's a couple of, and a lot of these needs, you know, they're community needs, and they pretty much breed community level approaches. And we continue to see that theme throughout as we gather this data and take a look at strategic initiatives that can help to address that. And so, as I mentioned, we have a consortium team that meets bi-monthly that takes a look at some of this data, and it's a group of diverse individuals. So I think as community members, really, as your voice must be heard. And so that getting in these rooms and saying like, yes, lead is an issue. We need more people to say lead is an issue, and support as well, support the city of Reading with our resources and where we can leverage our knowledge and education and expertise. And so we will continue to do that. And I encourage all who's on this call to continue and find those avenues as well.
Okay. St. Joe's, do you want to jump in or keep moving?
I would just echo Tanika's thoughts, in particular on the pledge to partner with folks who are out there who are far more involved and in the day-to-day knowledge of these kinds of lead issues and the abatement efforts we can put in to helping improve our health of our community is so important. As Tanika said, it's data that we continue to look at and understand in a better way.
Good. A second area that I wanted to get a question in on was COVID has really accentuated the importance of broadband access, the ability to access the internet and get information. And, you know, I'm a member of the Reading School Board. We did an aggressive outreach to try to get kids computers, get them access to the internet. But there are populations out there, low-income populations, elderly populations, populations with chronic illnesses. Have the health systems thought about ways that they can be actively engaged in trying to promote broadband access and access to the types of technology that could help those people ensure they get quality care?
We have an app for that, Dave. we have learned through this pandemic that telehealth is clearly an underutilized module that we can use in our communities. And by the way, the last statistic I heard, and Tanika, you're in the data better than I am, despite socioeconomic status, 97% of all citizens, all people in America have a smartphone. I think it's that high. And so when I say that, it's the truth. There's an app that we would have on our medical, you go on our website, you can ask a doctor. And so that's our effort. And yeah, there's revenue stream attached to it. I'm not going to not say that, but that's something that's not been really determined through Health and Human Services and or CMS. That doesn't matter to us. We know that telehealth and access to folks with the smartphone is really key to the wellness of our community.
Yeah, and now, Dave, I'll just add to that. So again, yeah, telehealth and telemedicine is definitely gearing up to be, a solution to this issue. However, we know with solutions, there's still more work to be done. So while, yeah, there a good number of Americans do have access to or have a phone, and then sometimes there's issues with that. Some people just don't know how to use it, or the list goes on. And at the hospital, we are actually looking into grants of how we can further support that broadband service and access. That's a great one. Thanks, Eileen. But yeah, so we at the hospital, we are looking at grants that will help to further support that and look more into telehealth and telemedicine.
Okay. Eileen, I don't want to let you entirely off the hook here. People in Berks County get a little tired of being compared to Lancaster on the one hand. On the other hand, it's always good to have models that you can steal from. What is Lancaster doing that's so different from everybody else in Pennsylvania?
That is a very good question. And it's one that I'm not super well equipped to answer, but I will say one thing that I have seen sort of as a more general observation is that, and I'm not sure if this is true of Lancaster, but like when you look at certain cities where there is like one healthcare institution that is serving virtually everyone, you see a much greater willingness to invest in these kind of upstream kind of community level interventions, because they can be very confident that like the results of that will lead to like lower, better healthcare outcomes for someone they're going to serve, right? So like the example we always point to, even though it's not actually formally in our district, is like UPMC is like the healthcare provider for everyone in Pittsburgh, essentially. And so when they do stuff like, investments to address like environmental pollutants, or, when they do, supplier diversity programs to build up, minority owned businesses in the area, like they can be pretty sure that like the downstream effects of, like the downstream positive health effects of like improved economic security and improved environmental quality are going to affect like people who they serve. So that is an interesting thing. I don't know if that's the case in Lancaster. Unfortunately, I'm not as familiar with the context there. But that is a pattern that we see a lot. Is that like ownership over a particular space?
Yeah, I'm going to cheat a little bit. Lancaster General and FNM were very, very actively involved for the last 10, 15 years in trying to promote redevelopment of the city, and did a lot of very interesting stuff in the corridor, what's called the James Street corridor between the two institutions. They moved the train station, they built a whole bunch of other sort of stuff. So they were really heavily engaged in it. I think it is a good example for how health systems and other anchor institutions can make a difference in a community.
Yeah, and you see a very similar thing with Cooper and certain neighborhoods in Camden, right, that they've really sort of adopted. And then, of course, the Penn health systems have a lot of, the Penn affiliated hospitals have a lot of engagement in West Philadelphia. So.
Right. We are at our end time. I do want to ask one last question because it links to an upcoming community forum that we're going to do. There was a little bit of discussion about engagement in early childhood education. How does that work with health systems as an anchor institution? Anybody? Any of the three of you? Including you, Eileen.
I guess I can just offer some of the examples that we saw in our review. So there was the example I shared that was a hospital in Cumberland County that was partnering with the local school board, not necessarily on, the childcare or pre-K provision itself, but on doing some of the supportive services around that, sort of knowing that that's sort of a good place to meet vulnerable families, where they're already accessing services and things like that. And then we did see a lot of examples of hospitals providing subsidized childcare on site, or providing their facilities for that use, which will show up in some of the community building spending categories. But I think there's a few different models for it.
Good. Okay, well, thank you. We have reached our hard stop, dead time. I want to thank all of our panel, Eileen, Jim, Tanika, Laura, Lisa, for doing this. It was a very good and very inspiring. It's great opportunities for our community to grow and develop, and the health systems as anchors of that really very, very important. So thank you all. I want to remind you that we will be sending the video of this, the recording of this, to everybody who registered. We've had everybody ask for copies of the PowerPoints that the three of you did. So if you're okay, we will send those out to everybody as well. And then we'll distribute the comments and questions that we had. Lots of good internal feedback about that. Lots of links to interesting and additional information that we'll be sharing with people. We will not be having a community forum in July. We will restart in August with our good friends at the Federal Reserve Bank, where we're going to be doing a program on accelerating economic mobility and workforce development. And we'll have a presentation by the Federal Reserve and a presentation by our Berks County Workforce Development Board, which has just released a strategic plan. And then in September, as I did a brief commercial for already, we're going to be doing a program on the economic case for early childhood education that will involve the Berks IU and again, our friends at the Federal Reserve Bank. So thank you. Thank you very much, everybody, for attending. Thank you to our presenters, and hope you have a great rest of the day and get at least a little time outside in this beautiful day. Thank you and goodbye.
Thank you.